a consultant physiotherapist. She's going to be talking about something which is fascinating, which is called critically appraised topics, CATS for short. So ask lots of questions. The afternoon is yours. And so I've just got a little quote from my quote book again. And this is one from Walt Disney, and he says, 1963, the way to get started is to quit talking and begin doing. So over towards you, Tina. Thank you.
That's great. Thank you for that introduction, Vanda, and it's a pleasure to join you all today at the Fab event and see all the wonderful work that's going on at RWT. And as Vanda says, I'm here to talk about CAT groups. It's not on the slideshow for me, Gabby. It is now. That's great. Thank you. If you could do the next slide, please. So I'm a consultant physio for part of the week, and the other part of the week I'm a knowledge mobilisation fellow, which means I'm passionate about getting research evidence into practice. What I'd like you to do in the chat, if we could, is to put your name, your professional group, and any special interest, and what you were hoping to gain from today's session. And hopefully we'll be able to achieve those things as the hour goes on. Next slide, please. So the brief was to familiarise folk with the key CAT groups and processes, but I'd also like you, along with sort of that introduction, to consider your next step with regards to CATs, or critically appraised topics. Next slide, please. So this is Kay Stevenson, who's a professor at Kiwi University and also a consultant physiotherapist. And it's around 20 years ago now that Kay first decided to look into this as a subject. She noticed that there were lots of physicians and physios and colleagues all completing master's degrees, but she was noticing that there was not a lot of the information that was being gained from the education being translated into practice. And she participated in a course at the Centre for Evidence-Based Medicine looking at CATs. Next slide, please. During the course, it was noted that healthcare which doesn't integrate evidence runs the risk of harm, but also misses the opportunity to benefit patients. And so, as well as the benefits that we know we can get from evidence-based practice, she wanted to look at preventing harm as well. But also how she'd noticed that staff weren't integrating evidence. So how could we do that? Next slide, please. Looking further into the research, there were lots of enablers to evidence into practice that had been identified. Next slide, please. We knew that if the change itself was likely to save time, energy and resources, that helped it to happen. If the patient's expectations of care or dissatisfaction with the current situations they were having, or if they'd had positive feedback from patients, then changes tended to happen. Within the individual professionals, there was their awareness around evidence, that their attitudes towards the evidence, but also their competency in relation to actually interpreting the evidence and getting it translated into practice. Next slide, please. Along with that, if you hadn't got people within the workplace who could actually lead this change, or actually the organisations weren't protecting time to actually enable those changes to happen, and then again, things would happen slowly. Another enabler would be government initiatives. If funding came along to support that change, again, that would happen. Next slide, please. They found that specifically around physiotherapy, if there was an increased of participation in research, then again, it would be translated into practice more rapidly. But they also noticed that they wanted quick and easy to read publications, not lengthy publications that the research would have to be published in. There was also a preference from staff for seeking human sources, so that they'd rely on known leaders, credible leaders to help them make those changes. And that's when roles such as knowledge brokers really started to come about. So helping this translation of evidence into practice. So out of all that research and all that course attendance, noticing these dilemmas around her, the critically appraised topic group, or CAT group, was formed. Next slide, please. So what is a CAT? We've talked about CATs. We know they're soft and fluffy, but they're not the ones we're talking about today. A CAT is developed from a clinical question, a clinical dilemma that you may have. Should I still be doing this? Is it harmful for my patient? Is this really the best thing that I can do for my patients? It answers those sorts of questions in a structured and answerable way. It enables us to provide a summary of that best available evidence by coming up with something that is termed a clinical bottom line. And that's a clear statement, easy to read, for us to actually then enact. And it's based on the best evidence within the literature that we've got. Next slide, please. This is back in the days when we all could meet face to face. So this is the allied health professionals group. So there are physios, OTs, dietitians, podiatrists in that group, as well as academics in those fields of excellence. And we would all come together quarterly at Keele and answer questions raised by clinicians. And this is how we would go about it. Next slide, please. We'd go through a CAT process. Next slide, please. The clinicians would come up with a specific clinical question. We'd then search for the best available evidence. We'd need to appraise that evidence, come up with a clinical bottom line, consider what that evidence actually meant for our practice. Changes were made, evaluate those changes and review, or if there wasn't any evidence to implement, we could put things forward for a new research trial to actually be taken place. So this process would actually benefit both the researchers and the clinicians, because if we come across a question that hasn't been answered by research, then that actually enables our researchers to take that question forward and fill that gap in the field. So let's look a little bit in more detail around each of those processes. Next slide, please. So to define the question, to get a specific clinical question, we use the Pico process, which some of you may be familiar with. So P is the patient or the problem or the population. I is the intervention that we want to look at. For instance, we could use a particular type of treatment. We then have C, which is the comparator. So what's the alternative to that treatment? And then the outcome, or what's the relevant outcomes that we want to look at? Quality of life, function, pain relief, particularly in physio. So that Pico format is how we would actually obtain the relevant materials to actually search for the evidence. So next slide, please. When we're searching for the evidence, we actually have the great help of our local librarians who work their magic around the search engines. What we're looking for when we're looking for the evidence is we're really looking for that highest level of evidence. We're not doing a systematic review. We're hoping that a systematic review has already been completed. So we're looking for those higher levels of evidence. The systematic reviews, your randomized controlled trials. More and more we are getting critically appraised topics being published, and the top of the tree being the meta-analyses. Next slide, please. Just to reassure you all, the searching is done by our Pam Collins. Next slide, please. This is to highlight all of the things that Pam does within the trust, but also how helpful it is for us not to actually go through the pains of doing the search engines ourselves. So we actually get the summary of the evidence summarized in a format that we can actually just screen the abstracts or screen the titles of the available literature, and then we have to think about appraising it. So Pam does all that hard work for us. We screen the abstracts, and next slide please, we come to appraise the evidence. Next slide, please. For appraising the evidence, what we actually do, and there's generally a group of 4 people to actually get together to do this, 3 or 4 people, and we use the Casp checklists. Is everyone in the audience familiar with the Casp checklists? If you have some raise of hands, or yeah, got some thumbs up there. So they're tools to actually help us to make sense of the evidence. Is this, just because something's published doesn't mean that it's gold, doesn't mean that it's actually being well done. We're often surprised in the group that something's being published even in peer-reviewed journals that perhaps it doesn't go through the scrutiny that enables us to give it a label of good quality for us to actually change practice. So we use these checklists to help us. Next slide, please. Thank you. And I think there's just a little bit of a delay, that's all. So the clinical bottom line, as we said earlier, it's a summary of the best available evidence written for the population who will read it. So this isn't going to be written in academic literature style. It's actually written so that us as clinicians can pick it up, and on the front page we can read exactly what we need to do. We can see the question and we can see that clinical bottom line, and is this of interest to me? Do I want to read the next couple of pages? So that's how it's been written. What I thought it would be useful to do would be to go through a couple of examples of CATs. Next slide, please. So that we could actually work through them together today, and for you to have some examples to perhaps think about. So next slide, please. So the first one that we'll talk about is around thumb osteoarthritis in the base of the thumb. So for the non-physios in here, or non-orthopedic folk over here, it's just at the base of the thumb. It's wear and tear, can be very painful and really restrict function because we grip everything with our thumbs. So lots of patients who get this really need help with pain relief. One of the mechanisms for pain relief is an injection. Next slide, please. And the issue that we had was that you could either have, for some injections, at a one-stop interface shop, so patients who were referred from their GPs with painful thumbs, what's best to do for them, they'd attend a clinic, and potentially if it was a knee or a shoulder, they'd get an injection on the same day. But the recommendations at that time were that for the thumbs in particular, we needed to do an ultrasound guided injection.